So as we very well know, blood transfusion is an important part of our day-to-day clinical practice. Blood and blood products provide unique and life-saving therapeutic benefits to patients. Available, safe blood and blood components are key prerequisites to transfusion. Appropriate use of blood and blood components is a key requirement in good standard practice in transfusion. The management of a quality blood transfusion practice is a multidisciplinary team process. As we very well know, as practitioners in hospitals, adequate blood supplies in Kenya has become a big challenge. This has become a challenge because the National Blood Transfusion Service that's got the mandate to collect blood and distribute it to health facilities has had challenges in mobilization of donors. It's also been compounded by issues of COVID, decentralization of government services. We know at the moment we operate as counties, and moving from one county to another one to look for voluntary donors and get blood is also a challenge. Hospitals and health facilities are resorting into replacement donations for blood transfusion. In many facilities, you have a relative admitted in a hospital and they require blood. The hospital is likely to tell you, bring one or two relatives so that they can donate blood for your patient. This is because, like we've said before, voluntary donated blood, which is ideal, most of the time is not adequate. Every other year, we have new health personnel recruited, from doctors to laboratory practitioners to nurses. And we know that the chain of blood administration requires all these personnel. Now, when we have new personnel getting into practice, they are not adequately trained on what really are either the appropriate blood or blood products transfused, and this training is very necessary to be provided. Equally, even those that have been practicing blood administration, sometimes they require frequent education on new things coming up, or just a reminder on what's quality and what's required in terms of blood transfusion. Now, Kenyatta National Hospital has a blood transfusion committee, and this committee meets once or twice every 2 months and deliberates on all the challenges that relate to blood, either challenges of availabilities, challenges of monitoring transfusion-related problems, and we discuss all these issues. We have a member committee of 16 persons, like we very well know, multidisciplinary transfusion hospital committees. They are comprised of all specialities. And in this case, in our hospital, we have the laboratory director as the chairman. We have an obs-gyn representative as a vice chairman. We have the laboratory manager as a secretary. We have a representative from internal medicine, he's also a clinical oncologist. We have a pediatrician representing. We have a representative from general surgery. We have a representative, an anesthetist for theaters. We have a pharmacy representative. We have nursing, and also she represents the A&E department. We have consultant hematopathologists. We have 3 of them. We have a medical officer who helps in mobilization for voluntary donation. We have laboratory technologists, and we have a secretary. And so going forward, when we have issues at any level of the hospital that require, that are related to blood transfusion, you can reach to either of these members and they'll be able to assist you. And right now, we go to our substantive topic of tonight. We are hoping that we shall be able to do more topics, but we are starting with this very important one on the beneficial use of blood and blood products. I have 4 presenters who are very experienced in matters hematology and blood transfusion. Dr. Rajab, Dr. Magutu, Dr. Makori, and Dr. Mudua. They will take up from now and educate us more on this topic. Welcome, colleagues.
Thank you so much, Dr. Mungania. I'm trying to share my screen. Just a minute. Okay, great. I'm hoping it's visible to everyone. Julia, I can see you're unmuted. You can see the screen?
Yes, we can.
Yes,
Okay.
yes, we can. Yes, we can.
Fantastic. All right, thank you so much. Good evening, everyone. Thank you so much, Dr. Mungania, for the very informative introduction. And I'd like to thank everyone for joining us today. This is day 4 of Lab Professionals Week, and we feel honored as members of the Kenyatta National Hospital Transfusion Committee to be able to present during this week. My name is Dr. Valerie Magutu. I'm staff at the University of Nairobi, and I'll be moderating this session. I'm really excited to introduce my colleagues and spend the next 1 hour or so talking about blood. And first up will be Dr. Julia Mudua, who's a pathologist who's both based at the Kenyatta National Hospital in hematology and transfusion, and also does some work at Othaya Hospital. Welcome, Dr. Mudua. We'll also have Dr. Jermaine Makori. Thanks, Dr. Mudua. We'll also have Dr. Jermaine Makori, who's the hemopath from KNH. And then we'll have Dr. Jamila Rajab, who's a hemopath with the University of Nairobi. Will be speaking to us as well. I can see Dr. Rajab is ready and online.
Yeah, thank you very much. Yeah.
Thanks, Doc. So the format of today's CME will be almost not quite case-based, but we're basing it on requests that we received in the last week from different clinical service areas at the BTU. Thank you so much to the BTU in charge, Perpetua Asuko, for providing these. I'll ask the presenters to make brief presentations based on these cards around the components that are featured in this requests. And we'll ask a few questions on the challenges faced, on how to utilize these products. And we welcome questions in the Q&A portion on anything transfusion, and also around the presentation that will be done today. But first up, I'd like to start us off will be Dr. Julia Mudua, who will take us through the structure of KNH BTU and our transfusion service as it's set up and the products they offer. Welcome, Dr. Mudua. I'll be driving in terms of the slides, so please feel free to tell me to go to the next slide or to slow down. Karibu,
Okay.
Dr.
Okay, thank you. So, good evening, everybody. I'll be talking on the structure of the BTU in Kenyatta. So the BTU is actually, the blood transfusion unit is actually a unit under the laboratory department, as we had been earlier told by Dr. Mungania. And Dr. Mungania is actually the deputy director of the laboratory department. The unit has 21 staff and comprising of 19 laboratory technologists and 1 health information officer and 1 support staff. So the role that the BTU plays is blood grouping and compatibility testing, replacement donor blood collection, screening of donated blood and blood component, and product preparation. Next. Doctor, you can move to the next. So we all know that the blood transfusion services are actually under the Kenya National Blood Transfusion Service, and the KNBTS actually supports KNH, and their support is mainly in supplying blood and blood products. But we realize that there's usually a gap because our demand is higher than the supply. Therefore, the KNBTS allowed various facilities, Kenyatta being one of them, to do donor replacement. Other support we get from KNBTS is when we have lack of blood products, we also can request them to give us a few blood products if available. They also assist us in screening of our blood products. They also assist in supporting the staff, especially when it comes to training. So that is one of the very important aspects of the Kenyatta the NBTS support to Kenyatta. Next. Okay, I'll look at the blood products and the components available in Kenyatta. But please note that these are not the only blood products that are usually available, but I'm only looking at the ones that are available in our facility. So one of them is the whole blood. I'll talk something small about the whole blood later. Packed red cells, platelets, fresh frozen plasma, and cryoprecipitate. Next. Okay, now this diagram just shows how we make the products, and the most important is the fresh whole blood. And in this fresh whole blood is where we actually get the rest of the products. So for 1 pint or 1 unit of fresh whole blood, it can actually, if you look at the diagram, it can actually serve 2 to 3 patients, whereby we have 1 whole unit giving us packed red cells, giving us platelet concentrates and fresh plasma. So 3 patients can actually benefit from just 1 unit. Next.
Thanks, Dr. Mudwa. I actually have a question posed in between that.
Okay.
Based on your presentation on the roles of the BTU. I think you've mentioned replacement donation or collection from replacement donors. Is that a traditional role of a blood transfusion unit?
Technically, no. A blood transfusion unit is only supposed to do grouping and cross-matching. All blood products actually supposed to come from the Kenya National Blood Transfusion Services. But as we had alluded earlier, our demand is way higher than the supply. And therefore, that is why we tend to do donor replacement. And when I say donor replacement, this is when you have given a patient blood, but request the relatives or friends of that patient to come and replace that same unit so that we can have another unit for somebody else. technically it's just a stopgap measure so that it can help us to
Meet supply.
To meet the demand.
Yeah, demand for the very hectic and specialized service areas.
Yes,
Thank you so
yes.
much for that clarification. I'm sure the COVID epidemic hasn't helped in terms of donor recruitment and blood supply, but thank you for that clarification. Before I allow you to move on, maybe I can ask, you know, a bit, on the screen, we have this lovely slide showing us that whole blood can be made into these components that can be used for, you know, exactly what's lacking, and to ensure that the patient only gets what they need. But are there instances that whole blood itself is used? And maybe you could take us through that and the indications. And I think that's what your next few slides are based on, actually.
Okay.
Maybe you can walk us through whole blood.
So for whole blood, there are very few indications for whole blood. So the whole blood is actually the donor blood plus the anticoagulant that is added in the pack. So the unit is usually 450 ml. And the main use of the whole blood, as shown in the previous slide, is actually to make component preparation. And usually if we store the whole blood, its shelf life is usually around 35 days. Now, the issue with whole blood is that there are no functional platelets and no labile coagulation factors, and that is factor 5 and 8. So the uses usually are autologous donation. When I talk about autologous donation, this is when a patient is being prepared for an elective surgery and has donated for themselves in preparation for that surgery. So in autologous donation, that is one of the uses of whole blood because we are returning back the patient's blood. Hypovolemic shock. This is hypovolemic shock stage 4. When I say stage 4, I mean blood loss of more than 2,000 mL. So when you want to rapidly improve the status of the patient, you can use whole blood. And then intrauterine transfusion. But please note that if it is a massive hemorrhage and you would like to have coagulation factors, you'd rather use the FFPs or the cryoprecipitate rather than whole blood because of the platelets are not there and also the labile factors.
Okay, thank you so much for that clarification, Dr. Muthua. We still get a lot of requests for whole blood, and even more so, we get a lot of requests for fresh whole blood. Not that we'd offer stale whole blood. Maybe you could talk us through the timing in terms of from donation to processing, this concept of fresh whole blood. Is there, you know, what would we be getting out of the unit? I think you've already mentioned that the platelets are gone. And is it something that perhaps we need to let go of as a concept?
Yeah, for fresh whole blood, it's a concept that we need to let go of because that fresh whole blood should be within, you should give it within 8 hours of collection. Now, within 8 hours of collection, it's a bit difficult in our setup because we have to screen that blood. The only time they use fresh whole blood is usually in the army setup in war situation. That's when they can be able to use the whole blood. But in our setup, fresh actually means less than 24 hours, which is not possible in our situation. So yes, so we need to change on that, yeah.
Thank you for that clarification and mentioning, you know, the walking donors in a military scenario. I know Jab will talk about freshness in terms of exchange transfusion, but I just wanted to maybe ask you to point out that when we are being asked for this product, fresh whole blood in a trauma situation, that maybe that term of freshness is a bit of a misnomer.
Yes, it is.
Thank you so much, Doc. So this is one of the requests we received last week from A&D. unfortunately, the consultant in charge didn't have a name, so I didn't have to block it out, for a patient who has anemia, and they requested 3 units of packed red cells. And packed red cells is actually one of the most commonly requested components. And I'd like you to take us through maybe what they are and their utility.
Okay. So, so packed red cell is one of the first components that we get from the whole blood. So the unit is approximately 285 to 335, so approximately 300 mLs. The hematocrit is usually around 65 to 75%, though we aim at 80%. The shelf life is 35 to 42 days. The reason why we have this range, it depends with the additives that we use. If we use an additive called Surgem, it takes us to 42 days. Say PD1 takes us to 35 days. And the storage is usually at 2 to 4 degrees. Next, so when it comes to the indication, as earlier alluded, it's the most requested blood product. And we usually use it for acute blood loss, greater than 30% loss of blood volume. And when I say 30%, I mean around 1,500 mLs of blood loss. And in this acute blood loss, most of the time is usually maybe traumatic events, active bleeding, hematemesis. Remember, we are also not only giving the packed red cells, we're also giving plasma expanders. We also have symptomatic anemia or chronic anemia. When I mean symptomatic anemia, basically our threshold in our country as per NBTS is we transfuse a patient with a HB less than 5 grams per deciliter. Though with symptomatic anemia, the threshold can increase to 7 or 8 depending on the clinical presentation. So that's why symptomatic anemia is there. Surgery is also one of the indications when preparing for surgical procedures, maybe like myomectomies. Next, it's okay. So in routine blood transfusion, usually 1 packed red cell unit can increase the HB by 1 gram per deciliter. In pediatrics, we usually do 10 ml per kg, and it's expected to raise the HB level by approximately 1 gram per deciliter. And usually when we are transfusing, we'd rather transfuse 1 unit at a time over a period of 2 to 4 hours. That's the period in which the transfusion should be running. And this transfusion should be done within 4 hours of issue from the blood bank. And we also recommend that transfusions should be preferably done during the day. In case of any reactions that occur, it's easier to get a team constituted to take care of the patient during the day rather than at night. Next.
Okay, thank you so much, Dr. Muga. I think also with staffing issues, daytime transfusions are preferable, though I know it's not always possible. There are usually more people around during the day to notice a reaction, as you've mentioned. I thought maybe you could comment on pediatric transfusions. You've given the volume per kg.
Yes.
Sometimes they do use a formula to calculate the deficit when they're trying to aim for a particular HB. Any thoughts on that?
Yes. Now, usually the formula is called correction of deficit, and the formula is they use total blood volume times in brackets the target HB minus the current HB over the HB of the donor unit. But usually the problem with that formula is usually getting to know the HB of the donor unit and the total blood volume of the child. But that's a formula that is usually used for the deficit, calculation of the deficit, yes.
All right, I know some other formulas cater for the total blood volume and add a factor of 5 or 0.5. But thank you for explaining the rationale behind it. And often we look at the volume per kg because the assumption of the child's total blood volume. Well, there's an assumption when we use the calculation. All right.
Yes.
And I'd also like to thank you for highlighting how the blood bank issues 1 unit at a time. I know often we get a lot of heat when someone's asked for 3 units and we only issue 1. Maybe you could comment a bit about that. Like, we just had that card, and sometimes we have residents tearing their hair out or wishing to tear our hair out over that. Why do we issue 1 at a time?
Okay, the reason why we issue 1, because the blood needs to be used within 4 hours. Once you have transfused the patient, it is good to also monitor the patient and see whether there's any reaction before giving a 2nd unit, and also actually assessing the patient after the 1st unit. Now, if we give 3 units at the same time, where are you going to store in the wards? 2, if it stays for more than 4 hours, then you have rendered our blood, can I say? We have actually we lose like 2 units already because of storage issue. So that's why we do one unit at a time. Yeah.
And actually, often blood banks give a cutoff of 30 minutes. If you've taken a unit, you have to return it within 30 minutes. After that, they can't accept it. So because it's a precious commodity, you're right, we are rather strict. But there are occasions when we do issue multiple products, and I think Dr. Rajab will cover that. Thank you so much, Dr. Mudhwa, for taking us through that. I think we can welcome the next presenter, who's Dr. Makori, but please hang around, Julia, for the Q&A. Dr. Makori, as I mentioned, is a pathologist at KNH, based in the Human Transfusion Department. If you're in KNH and you haven't met her, then you don't spend much time in the hallway, because she's always around and always available. And she's going to take us through a few other products. Dr. Makori, welcome.
Thank you very much, Dr. So I will take you through the transfusion of platelets and FFPs. That is a fresh frozen plasma and cryoprecipitate. As Dr. Mutwa has said, the types of blood products that are available in KNH are the red blood cells, the packed red blood cells, platelets, fresh frozen plasma. We also have cryoprecipitate. And these other components are already also available: albumin, immunoglobulin, and the factor concentrate, but these are rather commercial. So what we use from the blood transfusion unit are platelets, cryoprecipitate, and FFPs, as well as the red blood cell concentrate. My camera is not coming on, so. Okay. So as I said before, platelets are obtained from the whole blood after it has been separated. You obtain the red blood cell concentrate, then the fresh plasma that is on top. Then in between, you get a Buffy coat. Now from that Buffy coat, the Buffy coat is mainly composed of white blood cells and platelets. And also there are some platelets still in the fresh plasma. So through centrifugation, now you get a platelet pool. And that is actually plasma, platelet-rich plasma that you obtain. That is made now to be, it is added an anticoagulant. That is, citrate is used usually in that case. So platelet transfusions have been used since the beginning of the 20th century. Initially, in the early 1900 and few years, it was noted that when you use whole blood on patients who are bleeding, the bleeding tends to be controlled. Then later they noted that they could actually separate and get platelets and use platelets alone, and they were controlling the bleeding. But with the transfusion of platelets, there were many side effects. And this made, in 1986, the NIH sponsored a consensus for a conference where they studied now and reached the consensus on how to use the platelets. So in that consensus, they found that when you have a platelet count of more than 50,000 platelets per microliter, the bleeding is probably not due to low platelet count. So you have to look for other causes of bleeding. But when the count goes below 5,000 per microliter, expect severe bleeding. We are talking about major bleeds in patients who have very severe thrombocytopenia. Now, the issue between the counts between 5 and 50,000 per microliter, these are associated with high risk of spontaneous bleeding. And what we need to understand is when to transfuse, when not to transfuse. But this is not in question when we are faced with a hemostatic challenge. This is so for patients who need to go to theater. Maybe a patient needs to go for surgery and they have a platelet count of 30. In that case, there's no question that we need to top up that platelet count. And we'll see now what to do in different cases. So close to home, the KNBT has also issued guidelines for platelet transfusion. And this was for patients who are undergoing major invasive procedures with the lowest threshold for platelet count of 50,000 per microliter. And it was recommended that patients rarely need a platelet count above 100,000 per microliters. But this is recommended for those who are going for neurosurgical operation or operations that are where the posterior part of the eye is involved, where there is a difficulty in maintaining hemostasis. And we know other conditions like in uremic syndrome, where platelets may be there, but they're not working. And we need to know, do we need to transfuse such patients or we don't need? And I will go through that in my further in the presentation. Then it was also recommended that prophylactic platelet transfusion are not indicated for destructive thrombocytopenia. Here we're talking about things like immune thrombocytopenia because the immune system is already attacking platelets. By you bringing in more platelets, you are like adding oil to the fire. So this one also has to be considered. So you don't just look at the count, you have to know the clinical setting in that patient. So before we go further, we have now to understand where platelets work in the hemostasis. We know we have the primary and the secondary hemostasis, and platelets are involved in the primary hemostasis. This is where adhesion to the vasculature, to the endothelial cells, then activation of platelets, aggregation, that is why it happens. Then they form a plug. Unlike now the secondary hemostasis, where coagulation factors are the main players. And the end product of the secondary hemostasis is the fibrin thrombus. This is a more stronger thrombus than the primary platelet plug. And to check or to assess these two phenomena, you have to rely on laboratory tests. So when we are dealing with primary hemostasis, we look at the platelet count, we look at the bleeding time, and to check now for the platelet function, we go as well as to the platelet aggregometry. For secondary hemostasis, we look at the PT. This is where your INR comes in, the activated partial thromboplastin time, the APTT. Then, once any of them is prolonged or deranged, we go now to assess the specific factor assays. We are looking at the amount of the specific factor, first, which factor is involved, then its amount, then its function as well, because we know people can have enough factor, but it may not be working for different reasons. So each of these stages of hemostasis has different clinical manifestations. For primary hemostasis, we are talking about superficial bleeding. We are talking about mucocutaneous, these are bleeding from the gums, epistaxis, menorrhagia. But for secondary hemostasis, there are more deeper bleeds, hematomas, intracranial bleeds, such. But this is a reference, but you can still have with thrombocytopenia severe bleeds depending on the event that has precipitated that bleeding. So as I said, platelets are obtained from separation from donor blood. This is done within 4 hours after collection. Then they can also be obtained from apheresis. This is when you do a selective extraction from a donor, you get only platelets. And the advantage in this is that where the donors who are allowed to give platelets for apheresis, they first go through platelet count. This is what we don't get when we take whole blood, for example. We rely more on the hemoglobin level than on the platelet count. Then they are stored at room temperature. Here, I want to make it clear, I'm referring to our setup. Through your reading, you may find that there are other platelets that are obtained from the donor, then refrigerated. And this is a study that is ongoing. Maybe in the future, we'll be using refrigerated platelets, but in our setup, we are still using platelets that are maintained or stored at room temperature. And for this storage, they need to be constantly agitated. So they are not let to stay on a tabletop or somewhere like that, as much as it is at room temperature. They have to be constantly agitated. And the shelf life is 5 to 7 days. And during these 5 to 7 days, since they are at room temperature, every day, more than once, they have to be assessed. Turbidity, pH, things like those, cloudiness. And when you transfuse platelets, I'm talking about the therapeutic dose, and this is around 4 units for an adult. You will get a rise in the counts that is between 5,000 to 10,000 platelets per microliter. And usually this is where you aim at. The indications for platelet transfusion is thrombocytopenia. So we never transfuse platelets when we have a normal platelet count. It is always thrombocytopenia. But now this thrombocytopenia is caused by various reasons. It can be due to decreased production when you have a leukemia, patient on chemotherapy, some congenital disorders. We're talking about things like aplastic anemia, Fanconi anemia, severe liver disease, because in that case you get the liver is the one that produces the thrombopoietin. So when you have end-stage liver diseases, the production is reduced. Then you have an increase in or destruction or loss during DIC, that is disseminated intravascular coagulation, as well as massive transfusion. We can also have platelet function defects. This is what happens in myeloproliferative disorders or due to some drugs. As you know, some drugs can induce even some immune reaction. When you have immune reactions due to drugs, you can have those drugs making components with red blood cells that make them a target from the immune system and they get cleared. The same can happen to the platelets. We remember that platelets share some epitopes with the red blood cells, but we have drugs like aspirin or Plavix that are directly targeted at platelets, so they can lead to the platelet function defects. Then other conditions such as Glanzmann thrombasthenia or Bernard-Studier syndrome. These are syndromes where you have abnormal receptors to the platelets. Then it makes them not to be adherent or form the plug as expected. So the dosing of platelets is different, whether you are dealing with children or adults. For infants, we are talking about 5 to 10 ml platelet package. For adults, we go by units, 4 to 8 units. This is now the therapeutic dose. The therapeutic dose is 4 units, so 1 to 2. And this is calculated from the deficit. So the expectation is an approximate rise in the platelet count by 7 to 10,000 platelets per microliter. So you have to calculate now from the deficit because you are aiming at least 50,000 platelets per microliter. That is the count you aim at to stop the spontaneous bleeding. That is important to obtain a platelet count within 24 hours of transfusion. Ideally within 1 hour, because you can transfuse platelets and instead of having a rise in the count, you end up with a reduction in the count. And this happens because of several factors, and one of them is immune-mediated. But it can also be due to old platelets, overstayed platelets, as much as the half-life is 5 to 7 days, sometimes even after 3 days, then the body may react to them that way. And in cases of fever, sepsis, you can end up with refractoriness from the platelet transfusion. How to select platelets for transfusion? They should be ABO matched. We know how we select. If you have blood group A, we're going to give you A. Can you mute your microphone? Then
Robert Langat, please mute.
The same for rhesus matching. For rhesus matching, if you are rhesus positive, you can receive rhesus positive or even rhesus negative. But for recipients who are rhesus negative, like the neonates or small infants or women who are for childbearing age, we are not going to give them rhesus positive because they may create antibodies. If you are in a fix and need to give them, you should give the rhesus immunoglobulin, and this should be given within 48 hours of administration. But in our setup, we avoid that, so we just give rhesus negative platelets. There are several contraindications to the administration of platelets. If you are suspecting that your thrombocytopenia is immune-mediated, you are not going to transfuse platelets. Though to each of these contraindications, there are exceptions, but we prefer that you retain this. If it is immune-mediated, you don't transfuse. If you are dealing with a heparin-induced thrombocytopenia, administration of platelets is also contraindicated. In cases of TTP or HUS, administration of platelets will also be contraindicated. The reason for this is that in these cases, there are better agents that you can administer and help the patient without now aggravating the situation through the administration of platelets. In DIC, platelets will be administered only if there is bleeding. Dr. Rajab will take us through management of DIC with massive transfusion. Then we'll see there is room for platelet transfusion. Others are controversial, like in chronic aplastic anemia or myelodysplastic syndrome. If the patient is not bleeding, should you administer platelets? It has been documented that patients who have aplastic anemia, who intend to go through bone marrow transplant as the only curative treatment, don't benefit from repeat transfusion of platelets. Actually, those who get a lot of platelet transfusion tend to have a shorter lifespan than those who don't get. So unless the patient is bleeding, and we're talking about a major bleed, you don't need to transfuse platelets. Then when you are dealing with other coagulopathies, like in a hemophiliac patient, you give the factor that is deficient, you don't give the platelets. Because now you have to know where the defect is, whether it is primary or secondary hemostasis that you are attending to correct. Other constraint. Okay, now as any other blood component, there are side effects to it. You remember we are giving it from the donor, and these platelets are are anticoagulated with citrates, and some of the platelets-associated transfusion reactions are immune or non-immune, and may include like the lung injury, anaphylactic reactions, circulatory overload, citrate toxicity in case we are giving high amount of platelets. But specifically, among all the blood products we give, the platelets are the ones that are associated with septic transfusion reactions. And this makes sense because they are stored at room temperature. So the chances of a microorganism that maybe was on the skin and it found its way into the blood component and multiplied during the few days that it was being agitated at room temperature is very high. And acute hemolytic transfusion reaction, These are mainly from incompatibility from the donor plasma. Others are immunization due to class 1 HLA and other antigen leading to refractoriness. So we know that an immune reaction is going on when after transfusion, you check your platelet count and the count is as it was before or has even gone down. Then I can't also forget to talk about the post-transfusion papilla. This also is immune related and usually happens 3 to 4 days after transfusion. And as the immune system now starts attacking the platelets that were transfused, and it goes ahead and also attacks the recipient platelets. So whenever we are called to see a patient with thrombocytopenia, the first thing we are supposed to do is to check the peripheral blood film. It may not be on this diagram, but we know that the container we use in KNH for hemogram is the one that has EDTA as an anticoagulant. And we know that EDTA makes platelets form aggregates. So when you are dealing with a patient who has been found to have thrombocytopenia, we usually ask you to repeat. But the main thing, as thrombocytopenia is one of the critical values in hematology, we always do a peripheral blood film, and that is one of the things we look for. We look for aggregates of platelets. And if they're there, we recommend that platelet count is adequate because the platelets are there, but in aggregates. But in case they're not there and there is a true thrombocytopenia, if you are deciding whether to transfuse or not, you need to know what is planned with the patient. Is there any invasive procedure that is planned? If there is none, and the platelet count is below 50, you just observe the patient, whether the patient is bleeding or not. Have you excluded any immune-related thrombocytopenia? Because that one also you need to exclude it. Then from there, you will know how to proceed. As I said, for surgeries, the lowest threshold you should aim at is 50,000 platelets per microliter, unless the patient is going for a neurosurgical operation and you need to raise it to 100,000. But still, with all this, even a patient with immune thrombocytopenia with severe where platelet count is below 20 and need to go for a major operation where bleeding is expected, we will need to transfuse then to sort the issue afterwards. This patient, if it is an immune-mediated, should be on immune modulators. We're talking about steroids, IVIG, these are immunoglobulin. And as you give platelet just for the surgery, not really to cure the condition, because you expect them to go down afterwards.
Okay, maybe Dr. McCoy, I can interject there and ask a question that we often get. Sometimes we get a request for platelets and the blood bank is reluctant to give us platelets because the HB is low. Maybe you could comment on that.
Okay, that is actually very common. I get called a lot because of that. Now, we don't transfuse platelets unless the patient has thrombocytopenia and there is bleeding. Many times, you find that thrombocytopenia is associated with anemia. And if the patient is bleeding, we need to know what type of bleed is there and how low is the hemoglobin level, even the platelet count. Unfortunately, on the card we are currently using, there is no room for all that information. I hope that this is a temporary thing because plans are underway to change our request form to get to actually adopt one that was recommended by the MOH that has room for all the information required for each product. For platelets, we need to know those two counts. Now, when the patient is bleeding, if the hemoglobin level is low and it is, let's say, below 5, it makes sense that you will first correct the hemoglobin level before we move to platelets. Because as you know, in the primary plug, it is red blood cells and platelets that form that plug. So if one component is not there and you're giving just platelets, you won't achieve hemostasis. But if we are dealing with a platelet count of around 8, between 8 and 10, and the patient has a massive bleeding, you can actually start with platelets, then move on to correct the hemoglobin level. So I believe our BTU staff are on this forum, and they have also have to understand that we have to work together and consult each other in such cases.
Okay, but thank you for explaining the rationale that anemia in itself is a risk factor for a bleed, and that, you know, the red blood cells actually push the platelets to the periphery, just in case there is any breach in the blood vessels, which is why we do need, you know, the hemoglobin count or the red cell count to be normalized as well. All right, before we
maybe what I can add, sorry, Dr. What I can add to that is that we need to know that once you insist on continuing with blood transfusion, with packed cell transfusion, we are doing more dilution. So that platelet count, we are actually changing it and bringing it even lower, and the patient is already bleeding. So we should not be rigid and say 10. If it is not 10, you're not going to give you platelets. We have to weigh and ask what type of bleed is there.
Thank you so much. That's a really important clarification. Okay, so just as a segue into your next few slides, I have this card, a request from NBU. It was labeled urgent, severe anemia in a preterm. I've blocked out the identifiers, I hope. The HB was 11.2, but if you can see at the bottom there, the platelets requested were 13 mLs. Maybe you could take us briefly through you know, neonatal transfusion with regards to platelets.
Okay. Oh, okay. I thought I was going to talk about it. Okay, now.
Would you? So sorry. Did I rush? Would you like to comment on the card? I'm keeping an eye on the time.
Yeah. So.
Comment on this card.
So you see, let's start from the top. It is urgent severe anemia preterm, 5-day-old. Anemia, we don't know. The HB is 11.2. So it is actually severe anemia. Don't know where anemia comes from. Then they're requesting 1 unit and 20 ml packed red blood cell.
Dr. Langat, please mute.
Then packed red blood cells, 20 ml, platelets, 13 ml. So in newborns, actually in all children, when we're dealing with children, we always refer to the weight. So here, it is important to know what is the weight and the platelet count, so that even the person giving you platelets, 13 ml is very little. Yes. We know that whatever amount you're going to transfuse, half of it is going to go into the spleen and be cleared from the circulation. So when you're calculating like this, as I said, we use 15 to 20 ml. I don't know the weight of this baby. Let's assume it is a baby who is maybe 1.5 kilos. Even if it is 1.5, would be
it's still an underdose.
Like yes,
I agree with you, Doc.
This is very low. And this is where you need actually to go to BTU or call one of us, and we'll guide you. We are always available.
Thank you so much for.
So such leave now our staff in BTU confused because we don't even have bags of 13 ml. But that is the reality on the ground, you know.
Yes. Yes, but I guess they're all learning points. Whoever requested, please feel free, as Dr. Makori said, to contact anyone in the unit from the techs on the bench who are very knowledgeable. To any of us, we're usually available. Dr. Makori, maybe very quickly into the next couple of slides, because I can see we're almost running out of time, and your camera has moved.
Oh, okay.
I
will talk about now the thrombocytopenia in neonates. This is when you have a platelet count of below 50,000 per microliter. And usually it is not necessarily associated with the bleeding. And most of the time, we find that it is probably due to a tourniquet that has been left there for long or something like that. And the dose of platelets, as I said, 10 to 20 ml per kg. And in neonates, we mainly use platelets for prophylaxis. And prophylaxis is usually needed when you're dealing with platelet count of below 20,000 per microliter. And whenever it is between 20 and 50, unless there is a real danger in bleeding, or maybe you need the child needs to go and undergo a procedure where bleeding is expected, or exchange transfusion, you don't really need to correct.
Okay.
So platelet count below 100 won't be accepted for major surgery. That is why now we need to transfuse, as I said before. So it is similar to what I said earlier. But in neonates, the platelet counts tend to be low.
Okay.
And not associated with bleeding. So you don't need to panic, but you need to keep the neonate under your eyes to assess for any focus of bleeding, so that your intervention is timely.
Thank you so much, Dr. Makori, for that overview of platelets. Often when patients have thrombocytopenia, we get a request for FFPs for some reason. So please take us through the plasma products as quickly as you can, because I can see we're running a bit behind time-wise, though this is a very interesting discussion.
It won't take long. So FFPs are obtained from the plasma. So it is that plasma that has been separated from the whole blood. Once you remove now the packed cells and the Buffy coat, then you are left with the plasma that is frozen. And this plasma is rich in coagulation factors and is usually used to treat bleeding due to multiple coagulation factor deficiency. And we also use it in massive transfusion protocol when we're dealing with coagulation abnormalities. As any other blood product, it has contraindications, so we are not going to use it to correct the effect of things like warfarin administration, because you can get better results with vitamin K. So whenever you have a better solution, we avoid to give these blood components. So we never use it as a volume expander or as a source of protein. When we are having readily available factor concentrate, like now in the hospital, we have factor 8, we have factor 9, we have von Willebrand factor. When you are dealing with such a patient or such a patient comes with bleeding, you should not use the FFP. You better go to the factor that is deficient. It must be ABO compatible, and the dosage is 15 milligram per kg. This is for the loading dose. Then you can give a maintenance dose of 10 ml per kg and monitor with PT and APTT. Since it is the one you're going to monitor, we know in this case, in neonates, neonates are most of the time when you're dealing with them, the coagulation screening tests come out normal. You find INR is high, APTT is high, and people tend to react. But we know in neonates, for each day of life, especially the preterm, there is a reference range, they have a different reference range for those coagulation screening tests. As well, they are born with very low vitamin K. And we have quite a number of vitamin K dependent factors that cannot work in such environment. So when you are faced with that, you have to know that the first thing you correct what can be corrected. Like it is common, actually it is a practice that they have to be given vitamin K supplementation. The dosage in neonate is 12 to 15 milliliters per kg. But when you are going to use FFP, since we have experienced severe reactions to the neonates because of use of FFP, you should weigh the advantage against now the harmful effect that can have on your neonate. So avoid using it for prevention of hemorrhage. Rather use it to treat what is there once you have identified that the bleeding is caused by factor deficiency or multiple factor deficiencies. There are guidelines that have been set for administration of FFP in neonates. These are from the British Committee for Standards in Hematology. Vitamin K deficiency with bleeding, in DIC with bleeding, or congenital coagulation factor deficiencies where the deficient factor is not available, and I emphasize is not available. Then FFP has most of the coagulation factors if it is used as such, but you know, there is the cryoprecipitate, this is available in KNH. It comes in a small bag, it is 10 to 15 ml. And this is obtained from FFP. Once it is been thawed, then let to precipitate, the supernatant is removed, you are left now with the cryoprecipitate. This cryoprecipitate is very rich in factor 8, of course with the von Willebrand factor and fibrinogen, as well as factor 13 and fibronectin. It has several uses, but most of the time we use it when the factor 8 is not available for hemophilia A. We also use it in von Willebrand disease when we don't have the factor. And it can also be used topically in surgery as a source of thrombin when you want to achieve local hemostasis. Similar uses for in a neonate as a source of fibrinogen, especially in those neonates who have a low fibrinogen level, where it is lower than 1 gram per liter, with bleeding due to acquired or congenital afibrinogenemia or hypofibrinogenemia. The dose is 5 to 10 ml per kg.
Okay.
And it is readily available. So please, if you need it, you know that it is available to you.
Thank you so much, Dr. Makori. That was very comprehensive. And you really should cross over to the other side. Dr. Mungani, don't kill me. You're a very good teacher. I'd like to now welcome the last speaker for this session, Dr. Rajab, and I'll segue from this discussion that had a bit of neonatal and pediatric transfusion by projecting one of the requests that came in last week. Thanks again, Dr. Makori. Please adjust your camera. We can't see you. We can see your desk.
I don't know what has happened. It is on. My video is on.
Yeah, I think it's just an adjustment. No, I'm just getting a tour of your house. Okay. Well, no problem. Thank you so much, Doc, for that. Dr. Rajab, I think I'd like to welcome you as one our senior and two as the last presenter. Thank you, Dr. Makori, I can see you. And we'll start maybe by using this slide. We got this request last week. It was labeled very, very urgent for a 7-day-old female for urgent exchange transfusion. And they requested 240 mLs, said it was urgent, did not say what they wanted. But maybe you could use this as an introduction to your two topics for the day, which are neonatal transfusions and massive transfusion. Welcome, Dr. Rajab.
Thank you very much, Dr. Valerie Mabutu. I hope I can be heard well. And
yes, Dr. can hear you.
May I ask that I switch off my video?
No problem.
Okay, all right, but yeah, all right. So I'll just touch a little bit on neonatal transfusions, and then I'm going to look at massive transfusion and introduce the concept of massive transfusion protocols. Next slide. So if we look at the Kenyatta National Hospital, the statistics that I have in the last 3 or 4 months show that there's approximately 40 exchange transfusions annually. So about 3 to 4 exchange transfusions are done every month. There's about 250 neonatal transfusions, both small volumes and large volumes. And this includes neonates that need to go for surgical procedures. We don't have pediatric packs, so our blood transfusion unit separates using triple bags with estimated volumes. So if we have a volume that, sorry, Valerie, I know you are in a hurry. So each pack would probably have something like 150 mils of packed red cells because we don't have pediatric packs. We're working on setting up or writing up a standard operating procedure for transfusion of neonatal transfusions. I know that the Ministry of Health neonatal guidelines has a very elaborate page on triggers for transfusion for neonates, but I'm really talking about procedure in terms of, how do you set up the blood, what do you do, how do you warm it, and how do you monitor the transfusion. And this is mainly for the nursing staff that are in the newborn unit. Pediatric or rather neonatal transfusion requires that blood is warmed, and especially this is very important for exchange transfusion. We know that we have recommended that inline blood warmers should be available, but so far I think in my investigation in the neonatal newborn, we do not have blood warmers. Next. So neonatal red cell exchange transfusions are very rare. The incidence is very low. This is because of the various factors that I've put there. There's introduction of maternal anti-D immunoglobulin prophylaxis. In the antenatal period, there's more effective antenatal monitoring and treatment. And you should also note that our frequency rate for rhesus D antigen negativity is very low. It's less than 5% in the Black population. This is compared to 15% in the Caucasians. So the Caucasians would probably see more of the hemolytic disease of the fetus and newborn related to rhesus D sensitization, because that gives the most severe hemolytic disease of the newborn. Then there is, intensive use of phototherapy and use of intravenous immunoglobulin. So this makes the incidence of neonatal red cell exchange transfusion very rare. And you can see that we just do like 2 or 3 a month in the KNH. And usually the neonatal red cell exchange is usually a double volume exchange, and I checked the neonatal guidelines for the Ministry of Health, and it fits into this double volume exchange, and this removes about 90% of the neonatal red cells and 50% of the bilirubin to prevent kernicterus. Next. So indications of exchange transfusion is usually to prevent kernicterus in the hemolytic disease of the fetus and the newborn. And what it does is that it removes antibody-coated neonatal red cells and reduces the levels of plasma and conjugated bilirubin that would give bilirubin encephalopathy. Next slide. So this slide looks at the specifics for red cell neonatal exchange. This is a standard, the standard of practice. And usually you would want a unit that is plasma reduced with a hematocrit of about 0.5 to 0.6. And this also matches very well with that is specified in the Ministry of Health newborn guidelines. It should be in CPD anticoagulant, should be less than 5 days old. And this is for neonatal, this is, in quotes, fresh. I know that Dr. McCory talked about a fresh unit that should be 24 hours old, but for exchange transfusion, we can go up to 5 days for the exchange. Obviously, if the child has had previous intrauterine transfusion, then irradiated irradiated cells are indicated. And we have been debating about the possibility of irradiating some of our products, especially mainly the red cells, because irradiated units can be useful in a variety of clinical settings, including oncology. We don't screen for cytomegalovirus, but the standard practice is that all neonatal transfusions should be cytomegalovirus negative. And there's also an indication for the standards that the sickle cell screen should be negative for this unit, the donor unit. And usually what is issued is a group O with low titer hemolysins. Usually the hemolysins are the anti-A that will be found in group O blood. And of course, it should be rhesus D negative. If that's not available, because remember, rhesus D negative units are usually very rare and are classified under the rare blood, then you can give rhesus D identical with the neonate. And in other centers, it would also be KEL blood group negative, because we do know that KEL antigens are highly targeted for autoimmune disease and even alloimmune hemolysis. So it should be, the red cells should be red cell antigen negative for maternal antibodies, and they should be a cross-match, indirect and should be compatible with maternal plasma. So the indirect Coombs cross-match should be compatible with maternal plasma. So those are the specifics for exchange transfusion. If we look at large volume neonatal red cell transfusion, this is equivalent to a single circulating blood volume, which is usually about 80 mils in the neonates. And this is mainly used in neonatal cardiac surgery or probably other surgeries that require large volume transfusions. And a mean unit volume of 294 mils is usually the product that should be prepared. We know that in our newborn, in our blood transfusion units here, we do have the triple bag that's separated, and each has about 150 mils. And this should be in mannitol anticoagulant, and should be transfused less than 5 days from donation to reduce the risk of hyperkalemia. So this is large volume transfusions in neonates. And irradiated blood would be required for patients who are suspected to have T-cell immunodeficiency, which is very rare. And the irradiated unit should be transfused within 24 hours. Several hospitals around town, I know, irradiate their red cell packs. So the other transfusion that would occur in neonates is repeated small top-up red cell transfusions. This is up to 20 mils per kg, and this is common in anemia of prematurity. And we know that 80% of preterm babies that weigh less than 1.5 kilograms at birth are transfused at least once. So that's quite a bit of transfusion going on in the newborn unit. And the indications for transfusion in this group have largely been based on hemoglobin concentration and also the cardiopulmonary or respiratory status of the baby, in that, are they requiring oxygen? Do they have ventilatory support? And that, and factors such as weight gain. And although we know that there's been several randomized controlled studies that have addressed the risks and benefits of, the various hemoglobin triggers that have been given, and I'm going to show some of them. And the consensus is that there's the safe lower limits for hemoglobin transfusion in neonates is still very undefined, and we need more studies that we look at outcomes in terms of survival, in terms of neonatal complications like neurodevelopmental benefits in preterm babies. So that study is out there for the lower limit triggers for small volume transfusions in neonates. So these are just a summary of some of the triggers that I got from the MOH neonatal guidelines. And in the first week of life, if the HP is below 10, they'll transfuse. But if there's active bleeding with hypovolemia, then you transfuse whole blood. Patients who are on respiratory support, they'd like to maintain their hemoglobin greater than 12 grams, and anemia of prematurity, I think that should be less than 7. So if they have a hemoglobin of less than 7 grams per deciliter, then you transfuse. But again, even if it's 7 or more and they're symptomatic, for example, there's failure to thrive, if the child is having panic attacks or poor digestion and other conditions, then that would be a trigger to transfuse. So I have some figures here for triggers for neonatal top-up, small volumes. And you can see the hemoglobin here is in grams per liter, not grams per deciliter. So 120 would be 12. So first 24 hours of life, if they're ventilated, then at hemoglobin of less than 12, you would transfuse. If it's less than, if they're off oxygen, then you can use 10. And then you have the various categories just for comparison with our Ministry of Health guidelines. The specifications for the small volume transfusions for neonates, especially like anemia for in prematurity, you want a pack that has a hematocrit of between 0.5 to 0.7. It should be in mannitol anticoagulant, and it should have approximately 20 mils of residual plasma. That is the red cells should be suspended in 20 mils of residual plasma, and up to 35 days from donation. It's usually Group O is used, but you can use ABO compatible with baby and mother, and rhesus D negative is preferred, but also you can use, if you don't have that, or rhesus negative is in short supply, then you can use rhesus D compatible with mother and neonate. But we know that in many hospitals, usually the technologist or the service would release blood group O, rhesus negative, D negative unit. And it should be, of course, cytomegalovirus negative, but remember, cytomegalovirus is not one of the screening disease markers that we do in our service, and that is true even with the National Blood Transfusion Service. So a lot of the transfusions in the neonate is usually due to repeated bleeding, especially sick patients that need monitoring, and you're doing all manner of tests for monitoring, and some of the measures that you can do to reduce red cell loss in this little patients, this neonates, is to avoid doing non-essential tests, use low volume sample tubes, and we have those micro tubes that we can use for the neonates. You could use near patient testing, so that you could use capillary tubes, or use micro techniques in laboratories, and then the pediatricians could use like non-invasive monitoring where possible and reduce the need to bleed these neonates. And then you can reduce donor exposure by allocating a single donor unit. So what happens is that if you have a unit that's 400 mils or 450 mils, you can split it into pedipacks. And then if you have a sick patient that is going to require transfusions over the 35 days of storage, then you can just keep that a single donor unit for that particular neonate. But this requires very good coordination between the service and the newborn unit. So the typical small volume transfusion would be 10 to 20 milligrams per kg, administered at 5 milligrams per kg per liter. And transfusions of greater than 20 mils per kg are not recommended because of the risk of transfusion overload in the neonates. Next. Dr. Valerie, just let me know if time is really bad.
We are a little pressed for time, so
I need to really move very quickly. Okay, so just a reminder that at 4 months, ABO antigens are poorly expressed on red cells, and the corresponding ABO antibodies may not have developed. So, and we do know that maternal IgG ABO can be detected in neonatal plasma. And so that when we need a sample, that's why we ask for the maternal and infant sample, so that we can do grouping and cross-match on both baby and mother. And those are the tests that we do. We do an antibody screen on maternal sample also, and a direct scopes on the infant sample. Next.
So I was going to comment on
so if we go back to this card,
yes.
you want us to go back to that card? Okay.
I'd actually like to
discuss this. Hello?
Yeah, I think we covered everything pretty extensively, unless there was an additional comment you wanted to make on this.
No, not quite. Maybe like Dr. Makori said, we are reviewing our requisition cards and our requisition forms. And of course, like for this newborn baby, of course, we'd like the weight, we'd like the indication for the exchange transfusion. And the new requisition form will have some certain blood parameters that we want. For example, what is the current hemoglobin content of the child?
Thank you, Doc. All right, so the next card I have, actually kind of introduces the final topic, which I'm going to blast through, even though it's super important.
Yeah, I know. I'm going to have to really rush through this, back. And yeah. It's one of my favorite topics. But I mean, we are going to 20 past, but I'll have to just rush through it very quickly.
So we'll definitely ask Dr. Kinuthia for more time.
Yes, I think so. Yeah.
Yeah.
All right.
So the 21-year-old male, hemorrhagic shock, they asked for 2 units of platelets, 2 FFPs, and 2 packed red cells. So I'm just going to go straight into your next.
To the massive transfusion. Okay, so massive transfusion, and I'm hoping there's lots of surgeons and obstetricians on the forum, so they can maybe at the end give a little bit of their experiences and outcomes for their massive transfusion. And massive transfusion refers to a situation where greater than 10 units are transfused in 24 hours. But we know that a better definition that looks at a shorter time in terms of 5 units within 4 hours could be more useful, because this then you can identify the patient who needs a massive transfusion pretty early. And then there's the ultra-massive transfusion that is defined by, administration of more than 20 units of packed red cells within 48 hours time span. Next. And looking at, massive transfusion, there are several factors that will happen to this patient who has trauma or who has an obstetric bleed or a bleed massive bleed due to any other cause that will precipitate development of refractory hemorrhage, even in this patient who has severe hemorrhage. And what's going to happen is that once you transfuse, there's dilution of clotting factors, which includes platelets and fibrinogen. There's hypothermia, and I don't know, I hope I'll have time to go through some of these pathophysiologies that would lead to refractory bleeding in these patients. And then, of course, these patients will develop hypocalcemia, induced coagulopathy, and we know that low calcium decreases coagulation, and patients can bleed even more. And then, of course, there's acidosis because of the lactate buildup that will, send the patients into a refractory hemorrhage. So because of this, a lot of institutions have introduced what we call massive transfusion protocols. And this is a balanced transfusion of various products that will avoid dilutional coagulopathy and some of these factors that we've talked about. And remember, when you're doing a massive transfusion or when you have this emergency, you're not going to be able to get laboratories fast enough to guide how to use your clotting factors, how to use your FFP. So there's this massive transfusion protocol that institutions use to manage patients. So MTPs have been designed in various institutions, and this is one thing that the Hospital Transfusion Committee of the KNH wants to introduce. Our policy is going to come through in hopefully a month, and there is a whole topic on or guidelines in putting up an MTP that will guide massive transfusion in the various clinical settings, especially trauma and surgery and obstetrics. So MTPs have been designed, they've been validated, and there's lots of studies that have been done on operationalization of these MTPs. And just to make a case for MTPs, I've got some literature there and some few points that show that having a massive transfusion protocol in an institution is important. And several studies have been done to show that there's improved patient outcome with implementation of MTPs compared to physician lab-driven resuscitation, because that's what's occurring right now. Studies also show that there's improved mortality, and that has been attributed to reduced first time to transfusion of products, so that you're not transfusing fresh blood and then, hours later, then you think, oh, I need to replace my fibrinogen or platelets. So an MTP package, and I'm going to show you what it contains, introduces the packets very quickly. And Val, okay, I know. You can go back a little, and several other points that have shown that you can use very, very basic parameters of the patient, like heart rate, respiratory rate, and hematocrits to trigger an MTP, or to make a good assessment that this patient will need an MTP, a massive transfusion package. And also there's been studies that have been done that show that there's quite a lot of savings when you use an MTP. So these are points to make a case for having an MTP in an institution. Next. So looking at MTP components, the recommended component transfusion should be at a ratio of 1 to 1 to 1, and that is one packed red cell to one platelet and to one FFP and to one platelet. And it is said that you should avoid crystalloids, because crystalloids will further dilute your coagulation factors and can lead to also volume overload if you've used like 2 liters of crystalloids before now you begin to use your products. There is also in replacement of fibrinogen, we know that it gets diluted and you need to replace fibrinogen, and usually we use cryoprecipitate in centers where the fibrinogen concentrates are not available. We use cryoprecipitate, and this has been shown to be both useful in trauma massive bleed and obstetric massive bleed. Use of tranexamic acid is part of the MTP component. And there's been several studies, like the big crash 1 and 2 studies, and the HALT studies that have shown that using tranexamic acid actually benefits outcomes for patients with massive hemorrhage. And it's recommended, highly recommended in massive hemorrhage in obstetric practice. Patients usually get hypocalcemia because of massive transfusion, because of chelation of calcium by the citrate in the blood products. Usually patients will tolerate quite high levels of citrate, and the liver clears the citrate very quickly. But as you continue to transfuse, then the citrate build up, and the hypocalcemia develops. And we know that hypocalcemia will affect the intrinsic and extrinsic coagulation pathways and precipitate bleeding. So you need to replace calcium. Then there's hypothermia, and anesthetists in the group and surgeons know that patients who have had trauma, majority of them coming into A&E, studies show that almost up to 57 to 60% of patients who come in with trauma have hypothermia, and hypothermia can precipitate refractory bleeding. It also reduces the coagulation pathway in terms of activation of the enzymes in the cascade, and the patients will go into even refractory bleeding. So the other package for the MTPs, of course, whoever has the patient has to look for the source of bleeding. This is critical, and stop the bleeding, because that is the definitive management of massive hemorrhage. And remember, controlling bleeding might need a multidisciplinary team in whichever setting that you have. And then the last component is looking at the labs that you can do at the end when you know you have stabilized your patients and you want to check what your products have done, and you need to do your electrolytes and ionized calcium. You do your CBC, and of course you do your coagulation profile and fibrinogen levels. And then there are certain factors or certain parameters that tell you that now your patient is stable and you can stop your MTP. So what does this say? This says that next slide, Val, this needs that there is need for institutional support, and there is very good need for blood transfusion support. And I've just have a few copies of the MTP. I'm not going to go through them in detail. Like Val says, that we can have another session on this. And one of the things that the blood transfusion or the hospital transfusion committee is going to do once we operationalize the hospital transfusion committee policy is to train and go through these protocols. This is one example of an obstetric protocol, and the one before that that was on the other slide is one that has been used with lots of literature, lots of level 1, level 2 data and studies and expert opinions that looks at, a rationale for using the different components of the MTP that I have highlighted earlier when I was looking at the MTP components. So this is for coagulopathy and massive bleed, and the other one is for obstetric. But we do know that a lot of institutions will just have one that they use across a lot of the clinical settings. And the considerations for MTP, which I've gone through very quickly, which I would have liked to go to in a little more detail because it's something that we want to introduce and we are very excited about it, is that, there would have to be a very good service that meets the product demands and very good documentation. We need the role of the institution to maintain the drugs and the consumable stocks that are in the MTP. And then there should be a lot of training in the various areas, whether it is obstetrics, whether it is surgery, trauma areas, in the use and triggering of the massive transfusion protocol. And we need to have a very good hemovigilance team. And then all teams need to look at avoiding wastage in terms of who takes the responsibility to trigger the MTP and inform BTU that they need these components in these ratios. And what happens if there is blood products like FFPs and platelets that have been released, and this may lead to a lot of wasting if this is not well managed. And we do know that these products are very precious, and they're very expensive to process. So I think that is the end. Val, I'm sorry about that.
No, it's okay. I'm so sorry. I'm so sorry about that.
Anyway, I hope we're going to have other sessions to go through this well, and I'm sure that will be available. So thank you very much, and I hand over back to the moderator.
Thank you so much, Dr. Ajab. I am truly apologetic about the marathon and me pushing you to go through. You had a lot of important things to say, and I'm going to plead with Dr. Kinuthia that he gives HTC another session so we can go through a lot of these areas comprehensively. But that's it in terms of our formal presentation, and I'd really like to thank KNH-UoN for organizing this Lab Professionals Week, the research department under Dr. Kinuthia, our HOD, for the transfusion unit, Dr. Mungania, the in charge of BTU, Perpetua, her deputy Anastasia, the team, the Kenyatta HTC, and everyone who managed to attend. Dr. Kinuthia has graciously given us 10 minutes, so I'm going to stop sharing and try and look at the Q&A and maybe direct to the various panelists just over the next 10 or so minutes. We've been told we can go until 8:45. So, okay, Dr. Mudua, thanks for answering that live. We've got a lot of compliments. Okay. I'm trying to see which ones haven't been Been answered. Thank you, Dr. Barasa. Someone's asked about Luca-reduced blood versus irradiated blood. Are they the same thing? I can see Germaine is typing an answer. I don't know if you'd like to answer live. Dr. Makori? Is Luca-reduced blood the same as irradiated blood? Or any of the panelists?
Can I answer that?
Yes, please,
Dr. Rajab. No, they're not the same thing because irradiated blood is blood that has already been stored, and when it was stored, it already had the white cells in it. Luca-reduced blood is blood that is donated, and you use certain filters within a certain amount of time to remove the white cells. So they're not the same thing. And they're not the same thing because irradiated blood, we do know that white cells begin to deteriorate very quickly in stored blood, but they also may produce cytokines that will go into plasma and may cause reactions even in the irradiated blood. But in the Luca-reduced, you're removing white cells within a period of donation before you store it and before you get any components of the white cells within the unit. So they're not the same thing.
Thank you so much, Dr. Rajab. And just to add on, for your Luca reduction, things that will be avoided are things like your febrile non-hemolytic transfusion reactions that would be caused by the cytokines and the WBCs that Dr. Rajab has mentioned. And also it reduces the risk of CMV transmission. That's a discussion for another day. For irradiated, what we're really trying to avoid is transfusion-associated graft versus host disease, where the transfused lymphocytes engraft in the recipient. And this happens with patients who are immunosuppressed. Dr. Richard Aya has asked if we export any of the blood products. That is something I'm going to hand over to the panel. Do we export blood products?
I
can answer that.
All right.
We don't export blood products because we don't have enough. What we do, we are in communication with the surrounding hospitals. So when there is a unit we need that is somewhere else, so that is when another hospital has expiring products, they can bring them to us. As then we make sure that they have gone through the usual screening and such, but we don't export out of the country. We interchange with the surrounding hospitals though.
Yeah, thank you so much, because it is actually an issue of biosafety. We do not export, as Dr. Makori has said, but we have been very fortunate, especially through the consultants on the panel. If we are in need of blood, and also through the BTU staff, we do try to source from neighboring hospitals, and so far they've been extremely helpful, whether private or public. So thanks, Jermaine, for that.
Maybe just a comment on export. Yes, probably with the KDF, they would probably carry some units for if they're in combat. But this, we won't really consider it as exporting because it will be mainly for use for the troops that are in combat wherever, like in Somalia. They would actually, their teams do carry some blood products out of the country.
Thank you so much, Doc. They actually do. Thanks for that reminder. And also have walking donors who've been pre-screened, who then, donate in the field. And maybe we should mention that when dignitaries do come in, sometimes they bring products with them, but that's a different matter from export. Duncan Ajoy is asking, in situations whereby blood components are unavailable, any advantages of fresh blood over stored blood? Anyone from the panel want to take that? We have about 5 minutes. Dr. Rajab?
I don't, could you just repeat the question? Because I think Dr. Mudua handled that very well in terms of fresh blood and stored blood. What's the question again? I don't see it on the...
In situations whereby blood components are unavailable, is there any advantage of fresh blood over stored blood?
Okay, yeah, stored blood and like Dr. Mudua said, has and fresh blood, they have different properties, because fresh blood, and if you're talking about a unit that's 24 hours old, then it's still got some coagulation factors in it, right? And we do know that in situations of a massive hemorrhage, if you do not have components available, like the FFPs and the platelets that we've talked about, and you have enough fresh blood in your in stock, then you can begin to use fresh blood, and this would maintain your coagulation factors to some level as a stopgap before you get the components. But remember, components allow you to get higher increments of the factor that you want. If it's platelets, if it's coagulation factors, then the blood products allow you to get that desired increment. Stored blood, of course, there is no coagulation factors. And if it's the plasma properties change, because as you store blood, there is disintegration of red cells, and the plasma in which the red cells are embedded in, you can get hyperkalemia, you can get free hemoglobin in that stored blood, and can give you electrolyte imbalances. And if you transfuse a patient who has, for example, like renal function compromise, then you may get some problems because of the hyperkalemia and the free hemoglobin in the stored blood.
Okay. Yeah, thank you, Dr. Jab. I'd also like to ask Ajoy maybe to look at the INFORM trial that looked at, it was on packed red cells, but they looked at stored versus what would be considered fresh or super fresh. And there wasn't a real difference in outcome in terms of mortalities, though Dr. Jab has mentioned the situations in which you would want to look for fresh blood over blood that would be closer to the expiry date. But thank you so much for the extensive input, Dr. Ajab. I'm struggling to see other questions, and we have 2 minutes. I don't know if there's one burning one that can be seen by the rest of the panelists. Okay. Okay, there's some questions on COVID testing. I'll invite you to Friday's presentation. Platelet aggregation. Okay, Prof. Kidanga has asked that in the next CME we tackle the investigations of transfusion reactions, as they're hardly requested, yet we know they occur. Another complication for platelets in this era of COVID vaccination is vaccine-induced immune thrombotic thrombocytopenia, which is rare, but it is true. And thank you so much, Prof, for pointing that out. I don't know if our panelists, Dr. Ajab, Dr. Makori, Dr. Mudua, have any last things to say, or Dr. Mungania, our HOD, if there's any.
Dr. Magutu?
Yes, please.
I see a question on sickle cell disease by Mageto Lebol. He says, I have observed that sickle cell disease patients tend to have thrombocytosis. Kindly comment on it and highlight any risk that it might elicit.
Okay. So, okay, sorry, I didn't see that. Does anyone want to comment on the thrombocytosis in sickle cell disease?
I can comment, and you can have additions. We do see thrombocytosis in sickle cell disease. We know that sickle cell disease is a chronic inflammatory process, and patients would have thrombocytosis as we do know that chronic inflammation can give you thrombocytosis. So sometimes we see quite high, very high platelet counts in patients, especially when they're having crisis, because you're getting the vaso-occlusive episodes, and you get an inflammatory process that would trigger thrombocytosis. And I've seen sicklers that have levels of even up to 800 times 10 to the power 9 levels of platelets. So the cause is usually because it's a pro-inflammatory process. Yes. I don't know whether somebody else would like to add something.
No, I mean, it's usually a reactive thrombocytosis. It's not something that we aim to treat or correct.
Mm-hmm.
So I haven't seen an associated risk with thrombocytosis in itself in sickle cell disease, but sickle cell disease in itself is prothrombotic. So it's not the thrombocytosis, but it's the disease itself that would be a risk factor. Thank you so much, Dr. Rajab. Dr. Mungania?
Another one from Arifa. Most times I've seen oncologists give packed cells, 2 pints, alternating with normal saline infused with KCl. Is this within protocol? Patients inform us of having irritability effects, especially tingling body effects. Any comments?
I don't know why that would happen or why they're giving the alternate, because 2 units, unless the patient had like a high white cell count, Dr. Rajab or Macquarie or Madhu, I don't know if you want to chip in, because then if there was hyperleukocytosis and you were worried about adding packed cells, let's say, to the sludge, then we can give normal saline after the unit. But usually we don't give any other fluid other than normal saline. The infusion with potassium chloride is something that I haven't seen. I don't know if anyone else would like to comment.
Actually, what we are trying to avoid is hyperkalemia because of the tumor lysis syndrome. So now to add potassium to the IV fluids, I would imagine packed cells than normal saline, as Dr. Maguto has said, but adding now potassium chloride would actually exacerbate the tumor lysis syndrome. That one, I don't know.
Unless maybe for a specific patient, I don't know.
Maybe it's a specific patient. Maybe there was a specific deficit. Maybe we can answer conclusively on this. Maybe we'd refer you back to the person who was giving. But thank you so much, Dr. Mungania, for pointing that out, and thank you to the person who asked it.
I see we can still take another 2 minutes. How do you, there's one from Felicitas. Have you, sorry, it's the way it's framed. Do we have monthly immunovigilance analysis apart from transfusion reactions? That's due to lack of blood products such as packed RBCs and platelets. The delays sometimes are too much, keeping in mind national challenges in blood products. NICU is an intensive care unit, but served just like regular wards. Did we get the question?
Yeah, it's a multi-parts hemovigilance meetings. I think that's something that we do need to implement. I know, Dr. Mungania, under your stewardship and the former HOD, there have been a lot of hemovigilance officers trained, but maybe it's time to reactivate that under the HTC. But as part of the HTC, we do discuss and are supposed to discuss hemolytic transfusion reactions, not just hemolytic, but all transfusion reactions and all, adverse events associated with blood, and also blood supply. I don't know if the rest of the panelists would like to chip in terms of that.
Yeah, I think that's a very good question. One of the national indicators for a good transfusion practice is having hemovigilance data and that goes back to the National Blood Transfusion Service. This has not been happening. As you said, there were several, or rather very many institutions around the country had hemovigilance officers trained so that they can collect a certain data that would go back to inform practice and to improve practice. So this is something that needs to be operationalized. The staff are being trained. The data that needs to be captured is there. So it's really to just operationalize it. And some of the data or some of the factors or data that needs to be corrected is what has this particular person who is asking has put there in terms of deaths due to lack of products.
Okay.
Dr. Magutu, there have been so many hands up. Maybe you can just pick one to answer just one question.
Sure.
Can have them speak. The last one.
I didn't actually see, oh, okay, from the hands. Okay, I'm a bit biased, but I'm going to actually ask Prof. Githanga because she had mentioned something on that I would like her to answer. I'm unable to unmute her.
Can you hear me?
I've done that. I've done that.
Thanks, Dr.
Thank you. This was an excellent session by all the presenters. I posted what I was asking, but in addition, in sickle cell disease, platelets are very much implicated, and actually current studies where they're able to inhibit platelet activity has actually led to reduction in the vaso-occlusive crisis. So one of the things when we're giving treatments like hydroxyurea is actually to bring down the platelets as well as the white cells, which are also implicated.
Thank you so much for that clarification, Prof. Yeah, thank you. I actually saw your comment and realized we did need to address that. Dr. Mungania, over to you.
Yeah, this has been a very informative topic on beneficial use of blood and blood products. I sincerely want to thank my colleagues. The topic on blood transfusion is usually very, very extensive. We cannot exhaust it within one night, but we hope and plan to have more of these sensitization topics, whether on transfusion reactions, on cold chain. We hope our participants have learned on what products we have and what they can order for. And yeah, let's all keep educating ourselves. As regards laboratory and clinicians, I want to request that you communicate more often. I think it's terrifying to hear that a baby in NICU passed because blood was not availed, and yet you're requiring 10 units, 20 units. Please speak to us. You can speak to us on phone. I know there are usually complaints that we are not picking the phone. Sometimes we are too busy. If we cannot pick the phone, just walk down the laboratory. All the HTC members, representatives that we showed you, please talk to them. All your issues, if you channel through them, we can be able to iron them out. And yeah, for our participants, thank you so much. And let's meet at another time. Thank you. This is the end of the session.